Okay, so again, this is Trisha Harkness with Community Care Network of Kansas. Thank you all for being here today. We are going to discuss the quality reporting system so that you can submit your annual data. Um, we did send the slides out with I think the notification yesterday. Uh, there are a couple of minor changes on the slides that I made this morning, and so I will let you know what those are as we come upon them. But it doesn't really affect the content of the slides themselves. Uh, as is typical for anyone who's been on one of my webinars, I have a list of acronyms that I place at the beginning because that way, if you're not sure what that thing means, you can take a peek here. It's easy to find, and you can hopefully figure out what the acronyms are because I included all of them on the list. As far as housekeeping today, thank you for your time. We appreciate you sharing it with us today. Um, I was pleased that all of our health centers and all of our CBPCC grantees had staff who were registered for this meeting. So that is exciting, and hopefully you all will be able to get your questions answered or get a good idea of how the system is going to work for you for the 2025 calendar year reporting. Um, we would love to see you on camera if you can, but we also understand if you prefer not to be on camera. And you should be able to unmute yourself. So please only unmute if you have a question or something to share. If we hear background noise and we can pinpoint where it's coming from, Terry will help me get that muted. You can also use the chat function. And so you can ask questions in chat, and Terry will be keeping an eye on that so that she can let me know any questions that folks have. And so if you do have questions, if you could unmute and ask during a slide transition or type it into chat, that tends to work the best. But please certainly speak up and we will answer your questions. Uh, if someone shared this meeting link with you, so for example, if your participant name right now says clinic attendee, if you go to your name and you click on the little three button, I've heard some folks call it a hamburger button. Um, but if you click on that little button, you can go down to rename. That helps us know who was in the session. And so in the name of your attendee in our list, if you can make sure it's both your first and your last name, and your organization, again, that makes it easier for us from an attendance tracking perspective. Uh, On today's agenda, we're going to discuss what's new, also what data is going to be reported, and then I'm going to provide a demo of the Network Data Hub. Some of you who submitted your preliminary data may have taken a peek, so you may be somewhat familiar with it already. And then I'll share the technical resources that are going to be available. So what's new? One of the things is that QRS has transitioned to the Network Data Hub. And so we'll be moving more to that language of the Network Data Hub. So if you see that, please just understand that it is
Oh, I'm sorry. I'm sorry.
that it is the same, like it's the same reporting system. So QRS and the Network Data Hub, um, they were transitioned. So like I said, it is the same system. The requested data for anybody who has submitted data for us in the past has been significantly streamlined. We're trying to really focus on the things that we need to know so that we can support you all. And so hopefully you will see the differences and appreciate the reduction in data requests. All of the pages do now have a back button, assuming it's not the very first page, and have a next button. The final page has a submit button. This is true on both the preliminary data tab, which is now a separate tab, and it's true on the measures tab, the last page of the measures tab. So when you hit that submit button, it tells us that your data is ready for us to take a look at. The data entry has also been aligned with the UDS report. For the most part, you can just flow through. For our health centers, you can flow through your UDS report. The dental measures are the only place where you have to backtrack a little bit, and it's because of the types of measures that get reported. But again, hopefully that will help the data entry process flow better. Uh, Anything that is required for CBP/CC applicants is indicated in a dark red text. And so we just wanted to make it very clear which data is part of what we're capturing for the CBPCC grantees versus some of the additional data that we're gathering. And so you will see this both in the headers and you will see it on the pages over on the right, the sort of page navigation. Sorry, I got to mute for just a sec. Okay, the annual reporting deadline is April 1st, 2026 at 5 p.m. This actually aligns with the CBPCC reporting deadline. If you have any questions in the meantime, I will be sharing my contact information, and there is also a reporting email that you can send questions to. And then on the resources page, we are also having some office hour sessions. And so there are several resources that will be available to you to go through this process. Um, okay, so as far as the data that we're collecting, for the CBPCC data, we are collecting patients. Um, for patients, we're collecting unduplicated patients by income. Also, an explanation if your unknown income is greater than 25%. And in an element that is new, we are also collecting the visits for patients at or below 200% of the federal poverty level. That is a data element that anybody that submitted for the CBPCC grant should be familiar with, but it is new to our collection within this system. Also on the staffing and utilization page, which is the tab itself is staffing/UTILI for utilization. We are collecting medical patients and visits as well as dental patients and visits. There is some additional breakdown that we're requesting, but you'll see how we changed this aspect of reporting to focus initially at the top of the page on the pieces that are part of the CBPCC grant data collection. And then we're also collecting both medical, and then on the next slide, we'll have dental measures. So medical measures are ones that, again, you should be familiar with. They're weight assessment and counseling for nutrition and physical activity for children and adolescents, as well as body mass index screening and follow-up plan, which is an adult measure, the tobacco use screening and cessation interventions measure, controlling high blood pressure measure, and the glycemic status assessment greater than 9%. It was previously the hemoglobin A1C greater than 9 or not tested. So the measure is the same, but the title has changed. And so the dental measures, the quality measure is the sealants for 9-year-olds. We also request for clinics that have dental services that you report the visits by type. And so those emergency services, oral exams, prophylaxis, sealants, fluoride treatment, restorative services, oral surgery, and rehabilitative services. Those are kind of those visit type categories. And so that's where, like, if you're following your UDS report, you actually have to go back up to a different table because the services provided table is higher in UDS than the measures are. Some of the additional data that we're collecting, asking you to send us as well, is unduplicated patients by payer type, unduplicated patients by special and vulnerable populations, including special populations like your ag workers, homeless, school-based patients, etc., race and ethnicity, patients who are best served in a language other than English, and sex, which was previously gender. And this is per new federal guidelines, that's a male and female indication. And then we are also asking for your sliding fee data so that we can have an understanding of how much of your costs you slide for patients who are at 200% or below of the federal poverty level, as well as your staffing full-time equivalents. We also, in staffing and utilization by service, I'm sorry, give me just a moment. Okay. Sorry. And then, so for the staffing and utilization by services and staff roles, we're asking for your paid providers, those full-time equivalents, your clinic visits and your virtual visits, We also, if you have volunteers, there are places that you can report volunteers, volunteer hours, and volunteer visits. We did restructure those. So hopefully, because the paid side of it is on the left side, the volunteer side is on the right side rather than kind of mixed together like they were previously. So hopefully that will also help. Um, in addition, we previously we had asked for total cost of care that or total cost of medical and total cost of dental. We've actually transitioned that to a total cost of care measure to get an understanding because our clinics tend to provide a variety of services, and so we want to understand what that cost of care is per patient and per visit. So that's an amended data element. And then we did keep some questions on electronic information exchange and medication assisted treatment. But there are a lot of things that were collected in measures previously that are no longer being collected. If you are a health center, we do ask that when your UDS report has been finalized with HRSA, that you send us the PDF and the XML version of it. The XML version is one that we can import. The PDF version is one that is much more easy to read as a human being. And when those are available, if you could send it to that reporting at communitycareks.org address, that would be great. And actually, I'm going to see if I can get my chat to pull up. Probably just pulled up right in the middle of the meeting. Um, and so I'm going to put that link into the chat. Um, so you can send it there when you have those reports available. And then as far as, I mean, the purpose of the CBPCC grant data hopefully is very clear. Like we help support that grant through KDHE. Um, the way that we use that additional data is in grant support. So like when some of you reach out to us as far as supporting grant applications that you're doing, or when we are submitting grants to provide support for you, we use the data for that. We also use it for legislative advocacy. The preliminary data is actually part of our legislative advocacy because, the legislative sessions start in January. And so that preliminary data helps us know for the previous calendar year what you had as far as unique patients and what you had for visits. It also helps us tell our network story. And so that, like I said, as we were going through and kind of making some decisions about what do we keep and what do we not collect anymore, that was the reasoning behind the decisions that we made. And so for the network data hub, and again, I'm going to put this link in here. Due to preliminary data submission, hopefully you all have access to this. If for some reason you do not yet have access to the network data hub, would you reach out to me? Let me know. You can send it to that reporting email. I'll also be sharing my personal contact information. But when you go out to the network data hub, you will log in, and I'll actually pull that screen up over here. Terry, please confirm that you can see the network data hub screen now instead of my slides.
Yes, I can.
Thank you. Okay, so you will log in to the system. For those of you who still need to submit your preliminary data, like I said, this has been moved to a different tab. You just click on 2025. And so your clinic you can see your clinic's name here. If you do have any changes that you want to make especially as far as like contact information or something, let me know. Because on an admin side, we can make those changes. And so, if say your primary contact person, so the email that goes here, if that needs to be changed, let us know and we can certainly change that. But this is where you would look to see what your clinic's name is. So in this case, this is our training clinic. You will also note that there may be several community care staff that are listed in addition to your staff. And that's so that when we need to pull information that we can have access to that. So if there's anyone in your list that you don't recognize and you have a question about it, let me know. And that's probably our staff. But if it's not, we certainly want to make sure that I have everybody set up correctly.
Hey,
Um,
before you go
yep.
on, we can see your your last pass pop up. Yeah.
Oh,
It's
thank
kind
you.
of hiding
Let's,
some of the stuff a little bit.
okay, go away.
Try not now. I don't know.
Oh,
Oh, that's weird.
seriously? I've never had LastPass be that
I know, that's strange.
persistent.
Can
Okay,
you move
update
it?
maybe? No. That is odd.
How
Okay.
about
Oh, hey, did it
remove?
go away?
Yes. Thank you.
Oh, sorry, that was way harder than LastPass usually makes things for me. Um, okay, so like I said, if you haven't submitted your preliminary data, this is where that goes. It is your best estimate um, of total unduplicated patients and total visits, again, for calendar year 2025. Everything that we're talking about today is calendar year 2025. Um, this data, if it's not yet been submitted, is due by this Friday, please, at 5 o'clock, so that we can get that ready for the advocacy sessions that we are participating in with the legislature. The three tabs that are going to be the data that we're collecting are the patients tab, staffing and utilization and measures. And so in the patients tab, um, again, there's the red header to indicate that this is one of the things that's required for the CBPCC grantees. It is also red over here. When you enter the data on your screen, you can hit next. Um, and because this is required, uh, it's not going to let me hit next at the moment, but I believe I can also, yes, you can also navigate over here on the side. So if you're still working on your unduplicated patients by income, but you want to put your unduplicated patients by payer type in, you can just use the left nav or the right navigation pane. Um, if you have all of your data and it's there together, you can just keep hitting next. Don't worry about the lock data button. We'll actually do that once you have submitted your data and we've had a chance to review it. Um, so in patients, like I said, we're collecting patients by income. And so these categories should be familiar to you because it's 100% of federal poverty level and below, 101 to 150, 150 to 200, above 200% of the federal poverty level, and then unknown. And so if the percent calculation here, as you enter your data, puts your unknown at greater than 25%, that's when we do need an explanation in here. If it's less than 25%, please just indicate NA in this field because there's no explanation needed if it's under 25%. This is that new data element for visits for patient at or below 200% of federal poverty level. The patients by payer type, these are your insurance statuses. And so you're going to be reporting to us patients who are uninsured, who have Medicaid, Medicare, other public, CHIP, SHIP type insurance, and then private or commercial insurance. And then the unduplicated patients by special population. Again, this is the special populations are like your ag worker, your homeless, your school-based health center patients. Um, if you serve veteran patients, and then total residents of public housing. Um, that is within a specific range of federal housing or federal public house, not necessarily federal, in a specific range of public housing. If you hover over these, there is a definition that can help you. And we pull these out of the UDS manual, and so that is where we get that information. Your the vulnerable populations tab is your race and your ethnicity. And so in your UDS report, several of these are actually broken out into more granular categories for both race and ethnicity. We're just doing the roll-ups. And so, whatever your total for your Asian population is, for example, we're just looking for the total. We're not asking for any of that specific information for some of those more granular choices. If you have patients who refuse to report their ethnicity, it actually goes into this field in the line where unreported or refused to report race goes. And then we're also collecting patients best served in a language other than English, as well as male, female, and unknown. And so if it's documented as something different as far as like gender categories, then that can go into unknown. But from a federal reporting standpoint, they're looking for male and female, which previously I believe we referred to as sex assigned at birth. Um, and then the sliding fee data that we're requesting is how many patients had received a slide of their costs, sorry. Um, what percentage of your total patients, and this field may calculate. I should have double checked. If it doesn't, we can certainly calculate it based off of the data you provided on previous tables, that tell us what your total population is and what percentage of that your folks receiving a sliding fee are, and then the total cost of those discounts. Um, so that is the information on the patients tab. Do we
Hey,
have
Trish,
any questions?
there is one question. So I was like,
Okay.
before you exit that, Eric has a question, and I think it's referring to 2026 data. Yeah. With KDHE updating the charitable healthcare provider regulations to update the income limit from 200% to 300% of the federal poverty level. When determining a patient qualifies as medically indigent person, will we be expected to track or grantees be expected to track and or report that new population in 2026?
That is an excellent question, Eric, and I'm going to have to get back to you on that. Um, I I was not aware that that had changed, and so Terry, let's track this one for follow-up, um, because I would lean toward likely yes, but we need to certainly discuss that internally, and hopefully because since the system we've had, okay, it's effective January 9th. So thank you, Eric. That gives me some information to look at. I will follow up with my team and see if we do anticipate that as a change. Because we have the system updated and ready for submission, my hope is that next year that we are able to provide this training, some in early December and some probably in early January, so that we can prepare. But I will certainly ask that question and see what we anticipate as far as a different data collection. So thank you for that question, Eric. Sorry I can't answer it, but I will certainly find out what I can. Any other questions, Terry?
Nope, not yet.
Okay. Uh, so as far as staffing and utilization, what we had changed as far as the CBPCC grantee data is up here at the top is where you can report medical patients and your medical visits. Now, when you complete the breakouts, the total medical visits would be your combined um, provider visits, virtual visits, and then if you have volunteer visits, those as well. Um, and so that can kind of give you a double check on those. But previously in the system, we had your patient reporting down here at the bottom, and so we've moved that to the top to make that easier to find and report. We also changed what we're asking you to report as the breakouts. And so physicians, for example, had five or so, maybe seven, sort of breakouts as far as specific types like OB and internal medicine and that kind of thing. We're just looking for the total of your physicians this year, as well as your nurse practitioners, physician assistants, and certified nurse midwives, and those supporting medical staff like nurses, lab staff, x-ray, and other medical personnel. And so that data is part of, it got some streamlining into it. And then as far as your dental, again, we put the dental patients report piece up at the top and the visits. And again, you can kind of use your visits, virtual visits, and if applicable, volunteer visits to verify the total that you put it here into dental visits. But we changed it so that this first section, these first three categories, are your paid providers. These last three categories are your volunteer work. And so hopefully stacking those so that they're on their own sides will make it easier than rather than having them kind of interspersed throughout like they were previously. If you provide additional services, and so um, if you don't provide behavioral health services, then I mean, you would just, of course, leave the zeros in. But for any of these additional services that you provide, please also provide that information as far as your staffing and your visits. And then on these tables that are not CBPCC required data, the number of patients is actually down here underneath the table like it was previously. So you would kind of fill out the provider and the visit information, and then you would fill out the number of mental health patients. Substance use disorder services and those patients are also here. One of the things to also note is that FTEs can be fractional. And so you may have three providers that serve as 1.75 FTEs because they're all part-time, or two of them are part-time. For your number of volunteers, these are individuals. And so FTEs can be a fractional number. Number of volunteers, if you have volunteers, should be a whole number because we're reporting those as individuals, not as FTEs. We also have categories for other professional services. And so these are things like your chiropractors, naturopathic, occupational and physical therapists. I actually believe this definition, I think I need to update because I think this got more extensive in UDS, so I will verify that one. But those are those other providers that provide services that don't fall into the medical, dental, or behavioral health categories, or vision or pharmacy, because vision and pharmacy both have some provider types in it. And then as far as vision services, again, if you provide those, let us know what kind of staff and visits you have for them. Pharmacy, we're just looking for your staffing. The reason for this is that in UDS, pharmacy staff can't have countable visits. And so we're just looking for FTs, volunteers, and volunteer hours if you have volunteers. Your enabling services staff are those that are kind of assisting your patients with their navigation. And so your case managers, health education specialists, outreach workers, transportation staff, eligibility assistants. And so if you have like navigators, interpretation staff, community health workers, and then other enabling staff. And so again, these are generally your people who are helping your patients navigate both their health needs and some of their health related needs, which we previously referred to as social determinants of health. Um, and then also who sort of other programs and services and your QI staff, your facility staff, so like your management and fiscal, um, IT, those folks. And then the overall total that's at the end of this page, it totals this up. So there's nothing on this page that you actually complete. It actually pulls it from your previous list. And then I see Chris say on this may be covered under definition of clinician, but how do we treat telehealth services that we contract for? Um, as an example, we have a health service that provides behavioral health and other specialties in our clinic. Do we count these visits in our clinic visits or elsewhere? And so I believe the answer to that is that if I need to verify this, so don't hold me to this one, Chrisanne. I believe if the contracted work is someone that you pay or that you pay for the services, that you include them. Um, but if they individually bill the services, so like if you have a telehealth provider, and they do the services and then they bill them themselves, I think that's the difference. Um, hey Terry, do we have Mel on here by any chance?
She is not, but
I
we
so
can ask her.
okay. Um, so I will look that up to verify, Chrisanne, because like I think it depends whether you pay the person or like that person for providing services versus if they do it themselves. But let me verify that, and I will send that out in response, or send that out with the follow-up.
And I have two different scenarios for that. Would it just be helpful for me to
Okay,
email them to you and then maybe you can evaluate that way?
absolutely,
Yeah,
that
I'll
would
do
be
that.
fantastic. Okay, because yeah, then I'll take a look at it because I do, I know in some cases you do count contract providers, but like I said, I don't remember exactly where that line falls, and so I'll verify that. And when you email those, I will send like since it sounds like they're scenario based, I'll send out the response for both scenarios when we send out the follow-up for this meeting. Any additional questions? Okay, because I don't see any in chat. Anybody that needs to unmute and ask a question? Okay. Um, so the last tab that we complete is measures. And so medical and dental measures are required for the CBPCC grant if you provide those services. Um, if you provide medical services but not dental, or dental services but not medical, then you would only complete for the services that you provide. If you provide dental services, but you also check people's blood pressure, like there, you may report parts of the medical piece. Make sure on that you're verifying within your CBPCC application guidance on what for sure they want you to report if you only provide medical or you only provide dental services. Um, the the descriptions will tell you kind of where these measures fall. You can also, when it comes to clinical quality measures, um, dental sealants are not a CMS-based quality measure, so they are not going to be under the link I'm about to send. But the CMS, the ECQM, and I'm trying to remember the name of the actual center now. I should have written that down too. Um, they have the specs for the measures, and they are in a way that you can, it's the ECQI. Sorry, I saw it in the link now. Um, for electronic quality measures. These have the specs, and you can even compare them like current year to previous year. You can compare 2026's to what 2025's was. It's actually a really neat website. So I just posted that in chat, but it tells you like what the numerators are, what the denominators are, what the exceptions are, etc. So great resource. I highly recommend utilizing that. And as I mentioned before, this glycemic status, this was previously the A1C measure. They just changed it. And yes, Amy mentioned that ECQI and VSAC are my best friends. VSAC is very technical standards, and it does require a free user ID and password. But if you are the person at your center or your clinic digging into the quality measures, both ECQI and VSAC will give you lots and lots of information. Um, The other, like I said, measures that are required for CBPCC grantees if you provide dental services are these dental measures. Sealants, we base off of the UDS definition of that measure because it does not have a CMS equivalent. And so that's where we pull that information that if you have questions on that, the EC or the HRSA UDS manual would be the place to look for that. I'm also going to post that here real quick. Um, There are, if you look back several years, and I don't know how far you have to go, you can find a dental measure, but it's not one that they've kept updated for probably the last two or three. Um, and so, but that is a quality measure, so it has a numerator and a denominator. For the visit types, though, we are looking just for the visits. And so for the number of patients that you provided emergency services visits, that goes into the first line. If you provide two different types of services in one visit, so you provided emergency services as well as some sort of oral surgery. I don't necessarily know what those two things would go together. I'm not a dental person, so apologize if I didn't get that right. But you would go ahead and you would report one visit in each service type. If you did um, oral surgery on two different teeth, you would still just report one visit because it may be multiple teeth, but it was a single visit. So if you have any questions on that, let us know. We did note that in an example up here. And so, like I said, if two services were provided at one visit, do go ahead and report a visit in both services, but don't report multiple visits for the same visit if it was just multiple teeth. I feel like I kind of messed that up a little bit. So if I made it unclear, please let me know. Um, the financial measure that we move to, like I said, is this total cost of care. So when you um, know what your total cost of care is for the patient, then you enter that amount here. And so, this is costs that are related, for example, to like your staff and, what's required to provide those services, those kinds of things. And so you report that. It then uses your patient visit count, and then it pulls your patients from one of the previous tables as well as your visits from a previous table. And so those numbers should calculate by themselves. So the only thing that needs to be entered here is that total cost of care. On the electronic information exchange, that obviously is still a hot topic. How are we exchanging information with others? And so that's why we kept this question in there. So just indicate with a check mark however many of them apply. If none of them apply, just select G. If any of them apply, don't select G. With H, if you select that as an other, then note in the box below here what that other was. Um, and then as far as medication-assisted treatment, this has changed just because we don't require the data waivers, DATA waivers, for providers anymore. So the language on this has changed, but we are curious to know how many folks are providing those services, how many providers you have that can do that, as well as how many patients were served in the year. And that, folks, then is the last page. And so when you hit the submit button, it will prompt you and say, this is going to submit your information to community care. Are you sure? So, assuming that you're sure, please go ahead and click OK. It should now tell you, and I do have a screenshot when I go back to my slides, it should now tell you that you have successfully submitted your information, because that was some of the feedback we got with preliminary data submission is you couldn't really tell if it actually went through. So both preliminary data and on this measures medication assisted treatment page, which is the last page of data collection, anytime you hit a submit button in the system now, it should both tell you you've successfully submitted your data, and it should send an email to you to say, that data for whatever clinic was submitted on the date. So you'll have both an email and a pop-up. And so I'm going to switch back to my slides if I can get this to move. Uh, and so this is your data has been successfully submitted. Like I said, this is something that just got added yesterday evening. So if you submitted anything before probably today, you wouldn't have seen this. Hopefully anything submitted after today, you will see this. Any questions? And Amy noted in chat as far as those quality measures that VSAC uses your login.gov login if you use it for EHBs. And so for our health centers, the electronic handbook and is the place to go if you don't have the specs in something like Azara, which is a population health tool. So that would be another resource as far as your quality measures. If you do have a population health tool, they may have sort of info buttons that tell you, again, what those numerators, denominators, exceptions, and exclusions are. And they will tell you within VSAC, it tells you the specific codes involved. So if you're trying to figure out why is something in here, why is something not qualifying into my measure, VSAC is where you can really dig into those details. And then, Brittany, as far as your question, will pharmacy data outside of staffing be collected similar to previous years? No, not anymore. Because before we would collect some stuff around like 340B, we would collect some stuff around PAP, prescription assistance programs. Um, that data is part of what we have removed in the streamlining process. And so the only pharmacy data we are asking for is your staffing. Any other question? I'm going to go through some slides. If you have any other questions, certainly you can still continue to ask. Um, on the reports tab, there is a reports tab. We are still developing this, so please, like for now, um, don't use the reports tab. When those are ready, then we will send an update to let you know that those reports are ready and you can use them to pull your clinic's information. If there is data that, like as you're submitting data for this year, if there are things that for future years you think would be useful for you to get back out of the network data hub, that's what NDH is, let us know because one of the things that we're going to be able to do is create some customized reports. And so if there are things that you need us that you need to be able to pull back out in a report format rather than kind of taking a look at the screens, then certainly we can put that on a list of things to consider. And then, yes, an answer to Crystal's question only, and this is the slide about your question was very timely, Crystal. Thanks to everyone who has submitted their preliminary data. We've gotten quite a bit of it. We appreciate that. If you have not, and again, this is your total unduplicated patients and your total visits for calendar year 2025, your best estimate is due at close of business on Friday. The rest of the data that we went through today is due on April 1st. Thank you, Terry. You can always kind of tell people who have worked together for a while because um, she was on the same track that I was, so appreciate that. Uh, Terry did also share the evaluation link. Terry, if you don't mind, because we've had several questions, if you could share that in chat again. It really helps us understand how efficient our training is, helps us identify opportunities for improvement, and it enhances our grant reporting. If you submit those surveys, so please do so. And then I have a question from Penny. As we are working through our data, if our preliminary data changes, can we update it in the data hub? So my recommendation to you, Penny, is if it changes before the end of the day on January 16th, yes, because we've had some clinics that went in and changed their data and resubmitted it. And so the nice thing about this system too is we receive at Community Care an email that says this clinic has submitted their data. And so we know that it's in there and it's ready for us to take a look at. If it changes after the 16th, I wouldn't necessarily change it in the preliminary data. Obviously, of course, make sure that your data is finalized before you report the rest of the stuff that we talked about today. And so we do understand that because those two data elements are preliminary data, they're a best guess, that there may be changes as things get finalized through March, through February and March. Because for our health centers, of course, your UDS is due on February 15th and I believe has to be finalized by the end of March. And so if anything changes after this Friday, like I said, I wouldn't necessarily change it in the preliminary data because I will be reporting what we have in preliminary data as the end of the day on Friday to Aaron, who is our vice president, and maybe Terry can help me with his name or his title, but he is our advocacy, one of our primary advocacy people, and so we report that data to him. So anything that you change after the 16th, we may not end up capturing because it may already be into materials that we're using and that kind of thing. Does that sufficiently answer the question, Penny? It's kind of it depends. Okay, and so perfect. Um, any additional question? Whoops, I'm sorry, I didn't mean to go through all of them. I was clicking in the wrong spot. Uh, Any additional questions? I am going to share my contact information, and I'll share both my email address and our reporting email. The upside to sending it to our reporting email rather than me individually is that if I'm out of the office or something, um, that reporting email is kind of a group distribution email. So there are other people who have access to it that may be able to assist you in my absence. And so the reporting email I also just sent through. And then, yes, Crystal, on the information about telehealth contracted providers, my intent is to send that out to everyone that gets the slides and the recordings. And so hopefully that will get to all of you. Okay. Any additional questions? While you're thinking, thank you again for your time today. This actually went just a touch longer than I thought it would, so I do appreciate you sharing your time with us today. If you have any questions at all, certainly reach out to us. Um, and then my contact information is also in the slides. And so, like I said, you can certainly reach out to me individually. Reaching out to reporting, as I mentioned, goes to more than just me, so you may be able to get a response from others as well. And I see some thank yous, appreciate that. So you're welcome. And that is it for today. Wait a second, I skipped a resources page. Hold on. There we go. Sorry. Uh, so we do have some office hours coming up. There's one on January 27th at 1, February 10th at 9, and February 19th at 1. If you have not received those, I just sent them out. And they do, for those of you who attempted to attend my preliminary data office hours, it does have the passcode in them. Because I forgot that the first time around. So those are just come and go sessions. If you have questions and you want to pop in there, then you certainly can. If you've already emailed me or something and we've been able to answer, also okay. I'll just be kind of hanging out within that session for an hour to answer questions for anybody that pops in. There are also some resources and they are coming soon. January has been busy. And so there's a Network Data Hub worksheet that's going to have the data elements that need to be reported, as well as a UDS to Data Hub crosswalk. And so that's kind of a new resource that we're developing that will tell you, because the majority of these measures, with the exception of the visits for patients 200% FPL, the most of the rest of this data is in your UDS report for our health centers. And so that UDS crosswalk is going to say, for this data element, look on this table, on this line in these column or columns, and pull that information there. There are also on the homepage, there are Network Data Hub FAQs. Right now, they're kind of limited. But as we do have questions, and so for example, the question about providers, would get added to the FAQs so that you would have access to that. And any of those resources that we have will be on the homepage. There's a Network Data Hub. Let me bring that back up on the homepage. There's a link. Sorry, I was just going to show you where those resources are. So under here, these NDH resources, anytime those resources are published, this is where they'll be. The FAQs are already there, like I said, at the moment. They're limited. That worked better. But as the additional resources, so like the data worksheet and the UDS crosswalk, those will also get posted out to here. Okay. Sorry, I don't know how I managed to skip an entire slide, but let us know if you have questions. Thanks again for your time, and we will get, Terry had mentioned previously, the recording and the slides will be sent out to participants. Thank you all very much.
Have a great day.